All right, welcome back. Um, we're moving along now. Chapter 16 dealt with history taking, and Chapter 17 has to deal with doing a patient assessment. And we know that the patient assessment is standardized, but there are some slight differences when we're doing a medical patient assessment as opposed to a trauma patient assessment. Our assessment differs if we're dealing with a patient who's got a serious life threat as opposed to one who doesn't. So what we hope to accomplish here in Chapter 17 with the objectives is, let me move on to the next slide here. All right, there we go. We're going to explain the rationale for the use of an otoscope and an ophthalmoscope. We're going to define terms like inspection, palpation, percussion, auscultation, describe the techniques of inspecting, palpating, percussing, and auscultating, describe trending of assessment components, explain the value of trending the assessment components to other healthcare professionals who assume the care of the patient, describe methods used to locate and assess a pulse, differentiate locating, assessing pulses in the adult, child, and infant patients, distinguish among methods of assessing breathing in adults, children, and the infant patients, and differentiate patient with adequate or inadequate minute ventilation. We'll discuss methods of assessing mental status, differentiate assessing altered mental status in adult, child, and infants, categorize level of consciousness into the adult, the infant, and the child, recognize hazards or potential hazards when doing an assessment, determine and describe common hazards found at the scene of a traumatic event as well as at the scene of a medical patient, differentiate safe from unsafe scenes, describe methods of making an unsafe scene safe, discuss common mechanisms of injury and natures of illness, predict patterns of injury based on the mechanism, and discuss reasons for identifying the total number of patients at the scene. We're also going to organize management of the scene after we size it up, explain reasons for identifying the need for additional help and assistance, summarize reasons for forming a general impression of the patient, and explain the value of doing an initial assessment, state reasons for the management of cervical spine once the patient is determined to be trauma, discuss methods of assessing airway, describe methods used for assessing whether a patient is breathing, discuss the need for assessing a patient for external bleeding, describe normal and abnormal findings when assessing skin color, temperature, and moisture, describe the evaluation of the patient's perfusion status based on findings in your primary survey, discuss reasons for recognizing the mechanism of injury, analyzing the scene to determine if spinal precautions are necessary, explain the reason for prioritizing patients for care and transport, identify patients who require expeditious transport, differentiate assessment performed for a patient who is unresponsive and has an altered mental status, as well as other medical patients requiring assessment, and apply techniques of physical exam to a medical patient. State reasons for performing a rapid trauma assessment, cite examples, explain why patients should receive rapid trauma assessments, and apply techniques of physical exam to a trauma patient. Describe areas included in a rapid trauma assessment, discuss what should be evaluated, discuss reasons for performing focus history and physical exam, describe when, why a detailed physical exam is necessary, discuss the components of a detailed physical exam, state the body areas evaluated during a detailed physical exam, and explain what additional care should be provided while performing a detailed exam. Distinguish between a detailed physical examination performed on a trauma patient to that of a medical patient. Differentiate patients requiring detailed physical exams from those who do not, and differentiate normal and abnormal findings when assessing skin, hair, and nails. Distinguish the importance of abdominal findings when you assess the skin, abdominal. Distinguish the importance of abnormal findings when you assess the skin. Describe the examination of the head, the neck. Differentiate normal and abnormal findings of a scalp exam. Describe normal and abnormal assessment in the skull. describe the assessment of visual acuity, describe the examination of the eyes, distinguish between normal and abnormal assessment findings in the eyes, describe the examination of the ears, differentiate normal and abnormal assessment findings of the ears, describe the examination of the nose, and differentiate normal and abnormal assessment findings of the nose. Describe examination of the mouth and the pharynx, describe a neck exam, differentiate normal and abnormal assessment findings of the neck, describe assessment of jugular venous pressure and pulsations, differentiate between normal, abnormal assessment findings of the chest, describe examination of the anterior and posterior chest, differentiate characteristics of breath sounds, describe the examination of the heart and the blood vessels, differentiate normal and abnormal assessment findings of the heart and the blood vessels, describe auscultation of the heart, differentiate characteristics of normal and abnormal findings associated with listening to the heart, describe special examination techniques of the cardiovascular exam, describe abdominal examination, describe normal and abnormal assessment findings of an abdominal exam, describe abdominal auscultation, distinguish between abnormal findings when we auscultate the abdomen, describe the examination of female genitalia, describe the normal and abnormal assessment findings of the female genitalia, describe examination of the male genitalia, to differentiate between normal and abnormal findings of the male, describe examinations of the anus and the rectum and distinguish between normal and abnormal findings of the anus and rectum, describe examination of the musculoskeletal system, differentiate normal and abnormal findings of the musculoskeletal system, describe examination of the nervous system and differentiate the abnormal and normal findings of that system, discuss considerations and examination of infants and children, discuss reasons for repeating the primary survey, describe components of a reassessment, describe general guidelines for recording the examination information. Sounds like we're going to leave no stone unturned when we're talking about patient assessment. So let's look at the conducting a physical exam or doing a patient assessment. We've already had the chapter on obtaining a history, but in addition to obtaining a history, we're going to start actually physically laying hands on the patient and using those diagnostics that we have available to us to help us again determine what's wrong with our patient. Some of the tools necessary certainly are a stethoscope with a large diaphragm and a small bell. The large diaphragm is designed to pick up low sounds like a blood pressure, where the bell of the stethoscope is designed to pick up higher pitched sounds like wheezes. Then we've got blood pressure cuffs, and we all know that there's about 22 different steps to accurately taking a blood pressure, and certainly we can look at those when we do labs. And that there are different size blood pressure cuffs for different size patients. An abnormally narrow cuff is going to give you a abnormally high reading, where an abnormally wide cuff is going to give you an abnormally low reading. Ophthalmoscopes and otoscopes, not something typically that every ambulance carries and not something that you'd be really familiar with, but we certainly can use those to look into the back of the eye with the ophthalmoscope, and with the otoscope look into the ear and look for any debris, ruptured eardrums, that sort of stuff. And then, of course, the trusty old pen light used to examine pupil response to light, as well as to shine a light in to see the back of the throat. Some other tools include certainly diagnostic tools we have available to us, like a thermometer, so that we can obtain an accurate patient temperature, pulse oximetry, end-tidal CO2 monitors, glucometers, so we can get a blood glucose reading. All these things are important in our physical exam. Now, the exam techniques include the ability to inspect, palpate, auscultate, those sort of things. And we'll look first at inspection. Inspection is just a visual observation in order to seek physical signs that you can see. Looking at the patient for their skin color certainly is going to tell you a lot about their condition. Looking for swelling, bruising. If your patient's having trouble breathing, looking for signs of an increased work of breathing. Intercostal muscle contraction, nasal flaring, sternocleidoid muscle, I don't know, I can't say that this evening, but the muscles in the neck working hard when a person breathes. And then looking for things like a medical alert tag that might give you an idea of what's wrong with what their medical history might be. Auscultation is listening, and certainly we've all been taught to listen with the stethoscope, primarily to lung sounds, but also listening to the heart for heart sounds, listening over the abdomen for bowel sounds, listening in the neck for bruits. And then percussion. Percussion is certainly something that we could consider doing. I don't know many that use this technique in exam. You see physicians do it in the emergency department. Percussion is to strike the surface of the body and hear how dense the tissue is. If we get a really dull thud, like when you would thump a sandbag, then you know that the tissue is very dense, very full. We also call that resonant. But if we thump the body cavity and we hear timpani, and timpani is like when you strike a kettle drum, we also call that hyperresonant. And then flat would be no sound at all. Some other examination techniques include palpation, and palpating, we're looking for localized tenderness. And as we palpate, we certainly can see whether the patient is guarding their abdomen or involuntarily guarding their abdomen as well. Voluntarily, they may have some pain and they know it's going to hurt when we push on their abdomen, and so they may stiffen the muscles up in their stomach. Involuntary, it's just something that happens naturally, where their abdomen is distended and board-like and rigid, and guarding itself. Palpation also allows us the ability to determine skin temperature, moisture. It allows us to feel textures. It allows us to hear things like crepitus or the grating of bone ends. It allows us to determine shape, or perhaps swelling or abnormal shape. Texture, as we mentioned above, could be an induration, and that's a feeling of firmness, where you may also, when palpating tissue, feel a fluctuance. And a fluctuance is a wave-like motion in a fluid-filled space. Another part of our physical exam certainly is to obtain vital signs, and pulse being one of those vital signs. And we'll talk about initially wanting to know whether the rate is slow or fast, wanting to know what the rhythm is and whether it is strong, bounding, weak, thready. Those are terms we kick around to describe the quality of the pulse. Initially we don't need to know the number, but at some point we're going to want an actual pulse number. Respirations, again, initially we want to know rate. Is it slow or fast? We want to know whether there's good ventilatory effort. Are they breathing normally, or are they working really hard to breathe? Is their work of breathing increased? It's really important to note any sort of work of breathing, because work of breathing, in addition to telling you much about your patient's condition and the possibilities that might be causing that, work of breathing is a physical process, an active process requiring energy. And in some patients, they just don't have the energy stores to keep doing this. And if they're starting to wear out, that's where we see issues with, respiratory failure, leading to respiratory arrest and then cardiopulmonary arrest. So looking at their ventilatory efforts is important. The depth of their breathing, are they taking an adequate breath? Do they have adequate tidal volume? Is there some sort of recognizable pattern that you're seeing with their breathing? Are you seeing things like central neurogenic hyperventilation? Are you seeing things like Kussmaul's breathing or Cheyne-Stokes breathing, or Byatt's, which we'll describe in greater detail in lab? And then you want to listen to lung sounds as well. The sooner the better. We're often taught to listen to lung sounds during our physical exam, but there's nothing wrong with listening to lung sounds in the ABCs. Because one of the purposes of the ABCs is to determine whether or not the patient has any serious life threats. And you're not going to know whether they have a tension pneumothorax unless you listen to their lung sounds. And so if you can accomplish that, early in the assessment, the better. Blood pressure certainly is something that you want to obtain, and again, there are multiple steps to obtaining the blood pressure correctly, and we'll look at those. You can see that most of us probably haven't been taking blood pressures properly for a long time, and so I'm a fan of particularly in trauma patients, not obtaining blood pressures. There are so many other parameters that we can look at that determine how well they're perfusing, because a blood pressure, particularly in the presence of a head injury, really tells me nothing about perfusion, particularly perfusion to the brain, as we'll talk about in our head injury section. But with that, blood pressure is certainly something that we do obtain. The systolic is the top number, which represents the pressure in the system when the left ventricle contracts, and the diastolic is the bottom number, and that represents the pressure in the system all the time. And that's the pressure that left ventricle has to overcome in order to move blood through the system. So the higher that bottom number is, the harder your heart has to work in order to move blood through the system. Systole is just the description of the blood flow during the contraction of the ventricles, and diastole is the blood flow in the vessels constantly, or at least during the relaxation of the ventricles. Korotkov sounds. These are 5 sounds that are heard while taking a blood pressure, and most of us, when we do obtain a blood pressure, we pump it up till whatever sound we're hearing goes away, and then the first sound you hear is the systolic, and when you can't hear sounds anymore, that's the diastolic. Well, technically there are 5 different sounds that are heard while taking a blood pressure. And if you want to look up Korotkov sounds, Google that. You'll get an explanation of what those sounds are. We only, essentially use 3 of the 5, but there technically are 5 sounds that can be heard. Pulse pressure is the difference between the systolic and diastolic. And when the pulse pressure widens, that's an early indicator of shock initially, and then when the pulse pressure narrows, that certainly can be an indication of things like pericardial tamponade, tension pneumothorax, that sort of thing. Related to blood pressure, hypertension is a blood pressure that's higher than normal, and there's a variety of different resources out there that define what a normal blood pressure should be. The American Heart Association defines a normal blood pressure as right now anything 120/80 is being normal. And if your pressure is, certainly above that, then you might be what they considered hypertensive. They used to use 140/90 as their numbers. If your systolic was greater than 140 or your diastolic was greater than 90, then you were hypotensive. But they continue to lower that. It was 130/80. Now I think it's 120/80. Anything over that, you're technically considered hypertensive, according to the American Heart Association. Hypotension is when you have a blood pressure that's lower than normal. So, that's going to vary from one individual to the other as well. A little old lady with not much need for cardiac output is going to have a pretty low blood pressure. And for her, that or him, that may be normal. So you have to take those numbers in context with how your patient is doing. Body temperature is something else that we should measure. Normal body temperature certainly is 98.6. There's a variety of ways that we can obtain a body temperature. Tympanic is probably the most common way that people are obtaining temperatures. Axillary, you can get a temperature in the armpit. Rectally, with a rectal thermometer. Orally, with an oral thermometer. Don't get those two mixed up. And then esophageal temperatures, which is something that's relatively new in EMS, but if we're doing things or considering things like therapeutic hypothermia, being able to measure 2 different temperatures is important, and certainly they recommend rectal and esophageal as those 2 temperatures. Some of your newer heart monitors come out, have the ability to put an esophageal probe in the throat and actually measure the temperature, core temp. through the esophagus. You know, your body temperature has to be maintained within a very strict limit. You know, anything less than 95 degrees and, you know, you're hypertensive, or excuse me, you're hypothermic. You know, anything greater than 98.6 and you're considered hyperthermic, or have a, you know, low grade fever when your temp's 99.1 or 99.2. But your body constantly through metabolism is producing heat. And the heat that you produce has to be able to leave your body as fast as it's being produced. And there's a balance there. If your heat production is occurring at less a rate than your heat loss, you will become hypothermic. And if your heat production is required at a greater rate than heat loss, then you'll become hyperthermic. So, you know, neither one of those conditions are good, hyper or hypothermia, in patients. And looking at ways that heat can be lost out of the body include evaporation of sweat. Evaporation of sweat is one of the more effective methods next to radiation. You know, radiating heat, we are little biotherms, and we do radiate a certain number of heat elements out of the top of our head, certainly from our underarms, between our legs, our sides. You know, those are areas where we certainly radiate heat to the environment around us. When sweat is evaporated, it takes with it a great deal of heat as well. Conduction is actually the heat in your body is conducted to a colder surface, and you feel that when you sit on something cold. And then convection is wind blowing across your body, and with it it takes some heat. And you know, when you think about it, wind is important not only in you know, not only in helping us or causing heat loss in us, but if we didn't have winds, the average temperature on Earth would be somewhere in the neighborhood of 160 degrees Fahrenheit. So, you know, dissipation of heat by conduction, by convection is important. The wind blowing across your body surface, convecting heat out to the environment around you. And one thing that isn't really mentioned here at all, but we should be aware of it, is you know, the amount of heat that you lose when you breathe. You know, every time you exhale, you're exhaling warm, moist air. So in addition to dissipating heat, you also get rid of water. So that's two things that we often don't think of, but in a person who's working really hard to breathe, you know, not only is that an active process and they're burning up lots of energy, but they're also eliminating lots of body heat, and they're eliminating water. When obtaining a mental status, probably the easiest and most efficient way initially is just to do an AVPU. You know, is the patient alert, awake, and oriented times 4? Are their eyes open? Do they know who they are, where they are, a general idea of time and what happened? And if not, you know, their eyes are closed, do they respond to voice? And you need to speak in a loud enough voice that they can hear you, and if they don't hear you on one side, go to the other. Maybe they're deaf in that one ear. If there is no response to voice, then do they respond to pain? And there's a variety of ways to elicit pain. Most people have been taught to do a sternal rub, and a sternal rub certainly is painful, but sternal rubs may take up to 30 seconds in some people to register. So, you know, I don't know many people that do sternal rubs. I think I said 30 minutes, and it's 30 seconds. You know, you need to do a sternal rub for a good 30 seconds if you're not getting a response, if that's the method that you choose. The thing to keep in mind about sternal rubs as well when assessing for pain is that that's a reflex. That's really not a direct indication of what's going on inside the head, but that's more a reflex. I liken a sternal rub to when you put your finger in the hand of a baby. When you put your finger in the hand of a baby, that baby's going to squeeze your fingers, but you didn't tell it to do that. It doesn't know to do that. It doesn't know that's what you want it to do. It's just an inherent reflex. And so when you do a sternal rub, you're going to get some sort of reflex response, and that may not really be a good indication of mentation. So what I like to do, certainly when eliciting a painful response, is to squeeze the trapezius muscle or do an old Spock pinch in the neck, in that big muscle in the neck. By pinching the trapezius, I'm going to get one of 5 responses, which will answer all my motor responses in my Glasgow Coma scale. So if they are unresponsive to pain, then they are, again, unresponsive, which is the worst of the 4 conditions. So AVPU is a very quick and easy way to determine mental status, and if they are awake or they do open their eyes to voice, do they know who they are, where they are, a general idea, time, and what happened. At some point, when we rule out some of the more common causes of altered mental status, we should consider obtaining a Glasgow Coma scale. And a Glasgow Coma scale utilizes 3 things that we measure: eye, verbal, and motor response. And the score is 4, 5, and 6 respectively. 4 for eye, maximum score; 5 for verbal response; 6 for motor response. And when you look at eye opening, that's relatively straightforward. Are their eyes open spontaneously, or do they open them to speech, or do they open them to pain, or do they not open them at all? And they'll score appropriately that way. When you look at verbal response, are they oriented and can respond to you? They would score a 5. If they're confused to any one of the AAO times 4, if they don't know who they are, where they are, a general idea, time, or what happened, then they would score a 4. If their verbal response is inappropriate, they're using inappropriate words to the questions that you ask, they would score a 3. And if their verbal response, if their speech is garbled or muffled or that sort of stuff, it may be the right words that they're saying, but they come out muffled or garbled, you can't understand them, they would score a 2. And then they may have no verbal response. Now back to squeezing that trapezius muscle when you're doing your AVPU early in your assessment, your physical exam. Later when you're doing your GCS, you can compare the response you got if you had to squeeze their trapezius muscle in the AVPU to see if there's been any change. When you squeeze that trapezius muscle, it's connected to a cranial nerve that's connected directly to your brain. So you're getting response directly from the brain, and it's a good measure of mentation. Patients are going to be awake and obey commands. And if they aren't awake and their eyes aren't open and you can't get a response out of verbal or pain, when you do elicit pain, if they cross over, if they take their hand on the right side of their body and move it over to the left side to get rid of that left trapezius pinch, that's localizes pain. They know where they hurt. That's telling you quite a bit about their mentation. If they don't cross over to eliminate that painful stimulus, they may pull their shoulder away, and that's withdrawals to pain. And if they don't withdraw to pain, they may flex, and flex to pain is decorticate posturing. They may pull their arms up towards their core and flatten their feet out. That's decorticate posturing. Or they may extend, rotate their arms out in full extension. That's decerebrate posturing. They'd score a 2 there. Or there may be no motor response, in which case they'd score a 1. The purpose of the Glasgow Coma scale is it's a measure of the severity of head trauma, of the head injury. A score of 14 to 15 is okay. You get 12 to 14, somewhere in there. You got a mild brain injury. You get 8 to 10. You got a moderate brain injury. You get less than 8. You got a severe brain injury. But the Glasgow Coma scale really should only be obtained once you've ruled out other common causes for altered mental status. Make sure that they're not hypoxic, hypotensive, hypothermic, hypoglycemic prior to obtaining the GCS. Now, your general approach to your patient assessment should be systematic and organized. You know, we teach head to toe, but if you want to go toe to head, if you want to do the arms and then the legs, or save the arms and legs till after you've gone completely through the rest of the body, it's all up to you, just as long as it's organized and you do it the same way every time. Respect patient privacy, particularly adolescents. They may have issues with you removing clothing. Only remove clothing if it's necessary to do a physical inspection of the area, and if so, cover them up while the inspection occurs. And then communicate with your patient as you're doing your physical exam and doing your patient assessment, explaining to them what you're doing and why you're doing it. That certainly builds rapport and allows you to receive consent to continue. Excuse me, I'm going to take a drink. All that talking makes me a little dry. So your patient assessment begins with or includes things like a scene size up, an initial assessment, a secondary survey, and then reassessment. Certainly these are triangles. I believe the initial assessment, they include the secondary survey in there as well, but I like to separate that out. Your scene size up is what you've always been taught to do. Size that scene up. Is it safe? Is this an illness or an injury? Do I need additional resources? How many patients do I have? Is there a need for spinal immobilization? These are things that we should be thinking about as we're rolling up onto the scene and we get our first visual of the scene. Then you move into your initial assessment, which includes your primary survey. And the purpose of your primary survey is to find life threats. So during your primary survey, you're going to assess the ABCs. Some will add D and E onto that ABC, so you'd be assessing your ABC, D, and E. Looking at their airway, looking at their breathing, looking at their circulation, looking at their disability, which is the nervous assessment of the nervous system. And then E is exposure, because we certainly can't treat or fix what we can't see. So exposing the patient is part of that as well. You can't find a sucking chest wound if you don't expose the chest and look for it. You can't hear absent breath sounds on the side of a tension pneumothorax unless you do an exposure and look for it. So the primary survey, during the primary survey, we're going to, perhaps without even laying much hands on them at all, form our general impression. And we can form our general impression by thinking about appearance, breathing, and circulation. Appearance is to just look at them. Do they look sick? Do they look injured? Just looking at them, are they awake? Are they flaccid? Are they rigid? What position is the body found in when you get there? So appearance can tell you quite a bit about sick, not sick. Appearance can tell you quite a bit about how severe their injury is and whether or not they have a life threat. And then we're going to look at breathing, particularly worker breathing. Are they sitting in an upright position? Are they in the tripod position? Are they working really hard to breathe? Is their rate elevated and their intercostal muscles retracting and their sternocleidomastoid muscles? Sternocleidomastoid muscles in the neck, working hard as well. And do you hear anything? I mean, I've not got a stethoscope on their lungs yet, but certainly the old door test. You walk in the door, and if you can hear them wheezing from across the room, you've got a lower airway obstruction. Or if you can hear stridor on inspiration, you have an upper airway obstruction. And then circulation is just look at their skin. Are they pale? Are they cyanotic? Are they sweaty? What's the color of that skin look like? Some would advocate obtaining a capillary refill here, and some would argue that capillary refill is only good in children under 6. because adults have, peripheral vascular disease that affects circulation. They may be taking medications that affect circulation. Certainly the temperature in the room affects circulation as well. So cap refill may or may not be a good indicator of circulation, but certainly is worth a check. Again, in your primary survey, you're not only, looking for serious life threats, but you're also, establishing rapport with your patient. That's where you identify yourself by name and title, get yourself at their eye level, ask them appropriate initial questions to determine their level of consciousness. Certainly, grabbing that wrist to get a feel for their pulse is an appropriate initial touch, but you still need to ask them whenever you lay hands on them if it's okay to do that. And then also consider the emotional state of the patient and the family. The primary survey, when you're assessing the respiratory system, you're looking to see is there airway open. And not only is it open, but is it maintainable? I mean, it's one thing for me to open their airway and get them breathing well just by a head tilt chin lift, but then if I walk away, are they just going to obstruct again? Do I need to keep somebody on there to maintain that open airway? Look for airway threats. Look for foreign body airway obstruction. Look for stridor, wheezing, those sort of things. It certainly might be airway threats. Lots of vomit, broken teeth, that sort of stuff. Listen to lungs. Get an idea of their respiratory rate. Listening to lungs will cover in detail, certainly some of the sounds that you may hear, but it's important that during the primary survey, not later in the secondary survey that we listen to lungs, but listen to them earlier the better, as part of your breathing assessment. Where you listen to lung sounds, there's certainly a variety of different places that you can place your stethoscope. One thing that I found that's important when listening to lung sounds is, being able to know initially if they're moving enough air. And, certainly one way to know whether they're moving enough air is to listen out in the mid-axillary line under the arms. That's a good initial place to listen, rather than listen to the, 10 or 12 points where when here's outlined multiple different places to listen to lung sounds in this particular diagram. And I'm just saying that, if you're going to listen quickly to determine whether or not they have a life threat, then I would look at just listening out here in the mid-axillary lines to see if they're moving enough air clear out there. And if they aren't, that might be a concern. If a person is well, their bronchial sounds are coarse and loud, their bronchiovesicular sounds are normal. You hear air move in and out. Their vesicular sounds down around the alveoli and the bases, they're highly pitched and breezy. But if they're sick, you might hear rhonchi, which is a very coarse, low-pitched, bubbly sound indicating fluid in the bronchioles that they may clear with a cough. Wheezing or whistling, particularly on expiration, indicates narrowing of the bronchus and lower airway obstruction. Rub or a scratchy, high-pitched sound might be heard with inspiration as well. Crackles, fine, crackling, high-pitched sound that you might hear. I liken crackles certainly to the sound you hear when you pour milk on Rice Krispies. That will snap, crackle, pop. And crackles are an indication, some people call those rails, but crackles are an indication of the alveoli popping open. They're stuck together, they're collapsed, because as we sit around and don't need to take normal big deep breaths, a portion of our lung tissue collapses. And when we encourage them to take a really deep breath, if they've got a lot of atelectasis, a lot of collapsed alveoli, when they take that deep breath and those alveoli snap open, then that's a good indication of crackles. Assessing the pulse. Uh, where you obtain the pulse certainly might give you an idea about their circulation, whether the pulse is fast or slow, what their skin color, temperature, or moisture feels like where you're assessing that pulse. Again, we talked about capillary refill, and then looking at any signs of external hemorrhage. You know, if you can palpate a carotid pulse, some would say that you've got a systolic pressure of at least 60. If you can palpate a radial pulse, you got a systolic of at least 90. If you can palpate a femoral, you got a systolic of 80. If you can palpate a pedal, you got a systolic of 90. So that just gives you just a rough estimate of what your pressures might be depending upon where you obtain the pulse. In assessing the nervous system, certainly you're considering the potential for spinal cord injury, but more often you're doing that AVPU initially to determine the patient's level of consciousness. You also want to shine a light in their eyes to see whether or not their pupils are equal reactive. If you've got one pupil that's blown or doesn't respond to light, that may be the sign of a head injury. And then getting a blood glucose. While we don't consider that a test of the nervous system, it certainly is quick and easy and may explain why the patient's level of consciousness is altered. Once we've done our patient assessment and we've done our primary survey and we've ruled out our life threats, we can at that point determine whether this is a high priority patient or a non-high priority patient. Certainly with priority patients, we need to move quickly to get them to a facility to care for their illnesses or injuries, but non-high priority patients or non-priority patients, we can take our time and do things with those folks. Provide them a little more TLC, splint all their injuries and control all their hemorrhage and alleviate all their pain and improve all their breathing before we head to the hospital. Now, priority patients, some would say that, anybody who has severe pain is a high priority patient. Anybody having trouble breathing is a high priority patient. Anybody with an altered mental status is a high priority patient. Anybody with, weak rapid pulse is a high priority patient. Anybody with pale, cool, clammy skin is a high priority patient. So, look at perhaps what the practices are in your area to determine the priority of the patient. Once we've determined whether this is a high priority patient and we need to move or we need to stay and play, that's where we do our physical exam. That's where we get into our secondary survey and do things like our sampler history, obtain a good set of vital signs, and conduct a head-to-toe physical exam. Now again, your vital signs would be obtaining a pulse, and at this point we want to get a number. We've already determined where it's located and how it feels, whether it's slow, fast, normal, whether it's weak, whether it's bounding and strong, easily palpable, all those sort of things we've already determined. Respirations, here we want to get an actual number as well to maybe listen at other places besides the mid-axillary line for breath sounds. Other places that we can obtain pulses is the femoral pulse, and then the radial pulse, of course, in the wrist, on the thumb side, on either arm. And it might not be a bad idea that, in your next lab where you, after, hearing this, that you look at obtaining pulses in all these different sites. What they don't mention here is certainly a popliteal pulse behind the knee and a pedal pulse on top of the foot. Blood pressure, again, is certainly something that we obtain. I'm not sure that we do a good job of obtaining it accurately, but it is something that we get, and it helps drive some of our decisions, particularly trending. And we'll look at ways to obtain blood pressures, whether it be by auscultation, where we get a systolic and a diastolic, or whether it be by palpation, where all we get is a general idea of what the systolic is. We talked already about obtaining vital signs to include body temperature and the ability to use a thermometer of some type to get a good idea what their body temperature is. We already talked about, doing a mental status exam. Initially, ABPU works great. That's all we need to do initially. Once we've ruled out all the common causes of unresponsiveness or altered mental status, then we can look at getting a GCS. Noting their skin condition is important during the secondary survey if we haven't already, because we're going to want to expose the body to examine it. And in doing so, getting a good idea of what their skin is like is important as well. Getting a sampler history where we have the signs and symptoms, things that we're seeing, things the patient's telling you. Are they allergic to anything? Do they take any medications or OTCs, over the counters? What's their pertinent past medical history related to this complaint? What was their last oral intake? Again, events leading up to you being called, and then do they have any risk factors associated with what you think the differential might be? Our physical exam includes that head-to-toe exam, after obtaining vital signs and getting a sample and an OPQRST, NOPQRST. Then we're looking at doing a physical exam. And the physical exam should focus primarily on the area of the body where the chief complaint is. Now, if it's a systemic chief complaint affecting the whole body, then we're going to have to examine the whole body. But if it's a complaint of pain and the pain is located directly in one area, then we might just assess that one area. And when assessing trauma, we're looking for DCAP BTLS, deformities, contusions, abrasions, punctures, burns. I don't know if that's trauma or tears. The L is lacerations and S is swelling. When we assess the skin, we're looking for certainly color. Beet red skin might be an indication of hyperthermia. Might be an extremely late finding in CO2 poisoning, CO poisoning, carbon monoxide poisoning. Want to look for some peripheral and central cyanosis. If we have central cyanosis of the lips or the face or trunk, that's more concerning to me than peripheral cyanosis out here at the end of the hands. That could just be because they're cold. We want to look at hyperpigmentation. This is an unusual tanning or darkening of certain parts of the skin. That's a good indication of Addison's disease. And John F. Kennedy was probably the most infamous person with Addison's disease. And if you look at pictures of him, he has spots on his face where he has abnormal hyperpigmentation. You want to assess the temperature of the skin. You want to assess the turgor by tenting the skin, grabbing a piece of the skin and pulling it up in a tent and then letting go of it. And if it slides back, that tells you that, you've got enough collagen, you got enough moisture, all that other stuff is there. The elasticity is good. But in dehydrated patients, they'll have poor skin turgor. And when you tent that skin, it may stay tented for a while. You want to look at their hair. You want to look at their nails. That certainly might be an indication of, things like hypothyroidism. In assessing the head, palpate the entire skull and structure for integrity, pushing on the cheekbones, pushing on the forehead, pushing on the jaw bones, that sort of stuff. We're looking for the DCAP BTLS and trauma, looking for face symmetry. That means that both sides of the face look the same. You don't have facial drooping on one side. You don't have a drooping eye on one side, that sort of stuff. Again, DCAP BTLS. Also, in examining the head, we want to look for Battle's sign, and Battle's sign is bruising of the mastoid process behind the ear, and that's a good indication of a basilar skull fracture, as are raccoon's eyes. Raccoon's eyes are just darkening around the eyes as blood from a basilar skull fracture pools in the orbits and settles in the tissue below the eyes. That's not something that that's not something that happens quickly. That's something that takes a while. So when you see a patient with raccoon's eyes, the trauma or the problem may have occurred, a couple hours earlier. You also want to look in their nose and mouth for obstructions, narrowings, that sort of stuff. Excuse me. Again, a general shape or appearance of their face. Again, that goes back to symmetry. You also want to look at their eyes, and again, for symmetry. Are the openings the same on both sides? Is one eye swollen shut? Are they moving both eyes in unison? What is the physical shape of the orbit? The physical shape of the pupils? Is the sclera, the whites of the eyes, are they white or are they bloodshot? Are they jaundice? All signs of illness. Do they have any discharge in the eyes? Are their pupils equal and reactive to light? Are they really sensitive to light? When you shine a light in their eyes, does it hurt them? Are they really sensitive to it? There's a variety of tests that you can do to move the eyes up, down, left, right, in towards each other. And each one of those movements of the eyes represents whether or not a cranial nerve is intact. And essentially the second and third and sixth and fourth, looks like second, third, fourth, and sixth cranial nerves control those eye movements. So having them move their eyes in a given direction might tell you whether or not a particular cranial nerve is affected. You have 12 pairs of cranial nerves that are attached directly to your brain, and they go out to all parts of your head, your face, and your shoulders. You get below the shoulders, and here you're looking at motory sensory nerves that come off the spinal cord. You want to assess the eyes for movement ability, particularly in in patients who you believe might be intoxicated or under the influence. You can look at nystagmus, checking the eyes for any sort of darting or twitching as you move them from the center to the the far outside area of their peripheral vision, looking for a twitching of the eye muscle itself. That certainly may indicate the presence of drugs and alcohol. Vision tests are rarely ever performed in a pre-hospital environment, but again, you may not always work in a pre-hospital environment, so learning how they do their visual acuity test by usually having them cover one eye and read something off a chart, that gives you an idea again for how well their eyes are functioning. You can do a assessment of the outer ear with a flashlight, get a good look at it, make sure that there's no soft tissue trauma to the outside of the ear. Is there any blood or discharge coming from the ear as well, which may be the cause of, certainly again a basilar skull fracture, but may also be the cause of, an ear infection. To actually look inside the ear, we need an otoscope. And again, not something most people carry on the ambulance, but in an emergency department, you can use an otoscope to look into the ear and get a look at the drum, that sort of stuff. You want to assess the nose for shape. Does it look symmetrically in shape? Is it positioned squarely on their face, or is it canter off to one side or the other, which may be new or may be an old injury? Is there any bleeding coming from the nose? And understanding that, certainly if you have a basilar skull fracture and your sinuses are ruptured, you may get some CSF to leak out of your nose. Now that old test, the halo test of stuff leaking out of your ears, or a halo test of drops of blood on a white piece of paper that are coming out of your nose, that just really isn't reliable. There are certainly other fluids in your body that will separate out like that as well. And so to say with certainty that what you're seeing in a halo test is cerebral spinal fluid is kind of a stretch anymore. You want to look in the mouth and the back of the throat, again, for your DCAP BTLS, looking for blood, absent or broken teeth. Have they vomited? Is there any evidence of a foreign body airway obstruction? Is their tongue injured or swollen? Also, if you can have them open their mouth real wide and stick their tongue out, getting a good look at the back of their throat. If they have their tonsils, are they got pus bags all over them and swollen? If they don't have their tonsils, Look at the uvula hanging down in the back of the throat. Some people can get a viral infection of the uvula and have uvulitis, and that can become so swollen that people are almost like choking on it, and leads to problems that way. And then since you're at the mouth, certainly smelling for any unusual odors, the odors of alcohol, the odors of um, of acetone in the case of ketoacidosis. You're looking at the neck for swelling and bruising and inflammation. Are they having any difficulty swallowing? Is the trachea deviated? And a deviated trachea is an extremely late finding in tension pneumothorax, but if it's present, it's significant. If it isn't present, it doesn't mean you don't have a tension pneumothorax, because you've got to have significant pressure and significant collapse of that lung in order to get tracheal deviation. You're also looking at the neck for jugular vein distension, and here's a good example of a jugular vein that's fully distended. Oftentimes you can place your patient at a 45-degree angle on a cot, have them turn their head to one side and hold it there. And when doing so, you'll see that jugular vein start to fill and engulf, and if their blood pressures are good and that sort of stuff. Jugular vein distension may be an indication of a tension pneumothorax, maybe an indication of a pericardial tamponade, those sort of things. You want to check the neck before you put a cervical collar on, if that's what you're doing these days. Palpate that neck for tenderness. Certainly if there is any tenderness of the neck, if there is any tenderness of the back, if there is any numbness or tailing of the spine, then we certainly would advocate putting a cervical collar on, an appropriately fitting cervical collar. Understand that when you do put an appropriately fitting cervical collar on, the patient still has a 52% range of motion. So cervical collars don't immobilize, but they do remind the patient to sit still. And also assessing the neck, some will place a stethoscope over the carotid artery, listening for bruit. Bruit is a whooshing sound that you can hear as a result of turbulence or blood flowing through narrowed carotid arteries. So it's a sound that you'd have to hear in order to, it's a sound that you'd have to know what it sounds like, kind of like a whoosh, 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 when listening over the carotids. The presence of bruits tells you that the carotid arteries are narrowed, which may explain or be the culprit for a non-hemorrhagic stroke. You also want to palpate for swollen lymph nodes and look for signs of infection. And here's a variety of different lymph nodes and where they're located in your face and your neck. So palpating those particular areas to see if any of those nodes are swollen is important as well. Listening to lung sounds. Here at this point in the comprehensive patient assessment, where we've already ruled out our life threats, we're going to want to listen to lung sounds in a variety of different places across the chest and back. I think it's important to get a good idea of what their lungs truly sound like is that we have them take deep breaths in and out with their mouth open. In doing so, they have a tendency to move more air, and in moving more air, their sounds are more pronounced. We already looked at this already, which indicated the type of sounds that you're going to hear when listening to lung sounds, and hopefully they're very very clear. But if they're not, if they're wet, bubbly, gurgly crackles indicating fluid, then they're going to need attention. Noisy breathing is obstructed breathing. You want to assess the chest during your secondary survey as well, palpating the ribs, looking for equal chest rise and fall, palpate the sternum, particularly in chest trauma from steering wheel. You want to check for pulse strength and look for peripheral edema as well. Not only peripheral edema in the legs, we often look for pedal edema, but you certainly can have sacral edema. You can have swelling all the way up both legs. And that's something you don't see very often, but when you do is certainly an indication of a significant congestive heart failure. You want to listen to heart sounds, and I'm not big at listening to heart sounds. You know, you need to be able to use both the dome side of your stethoscope for those low pitch sounds and the bell side for those higher pitch sounds. You're essentially listening for lub dub, and when you have that nice lub dub, that's certainly what you would hear with um, normal heart rates. If you're hearing lub dub dub or lub lub dub, those could be indications of valve misfunction. The abdomen we're going to divide into 4 quadrants, and the reason that we do that is it certainly helps us identify the organs that lie underneath those quadrants and what may be the cause of the patient's discomfort. Some would advocate that we palpate the abdomen for tenderness, particularly rebound tenderness. Rebound tenderness occurs in somebody with an acute abdomen. They've got an abdominal catastrophe going on, and you're in there pushing on their belly really hard, and then immediately letting go so that their belly springs back to normal. And that to me is cruel and unusual. If a person's abdomen hurts, I certainly might have them point to where it hurts to give me a clue as to what sort of organ might be involved, but I'm not a fan of just randomly palpating the abdomen to elicit a pain response. The abdomen may be rigid, they may be guarding, there may be palpable masses easily palpated in the abdomen, which certainly would indicate a AAA. In assessing the genitalia, certainly the only reason there would be a need to assess the genitalia is, in trauma to the area. We certainly would need to assess it. Or if we're dealing with, an imminent birth or the birth of a baby, we would need to assess the female genitalia as well. The only reason to assess the anus is certainly if there's some rectal bleeding or severe anal pain, like in the case with hemorrhoids, where you might get both. You might get real severe anal pain if the hemorrhoids are significant, and you may get some hemorrhage as well. But typically that's just not something we assess unless there is rectal bleeding or severe anal pain. And you got to have the patient's permission before you go probing around there, and respect their privacy as well. And it is part of the assessment. Pelvis, we're going to check the pelvis for deformity. I'm certainly not a fan of that either. If you rock the pelvis, you certainly increase the risk of making the fracture worse. If you bind the pelvis, depending on what you're using, there's no 2 binding methods that are identical. Even if you're all using the same piece of equipment, binding that pelvis is accomplished differently by whoever does the binding. So it's not an exact science using a binder, and it may be detrimental in some patients. So I'm an advocate that, if I believe they have, an injury to their pelvis, I just tie their ankles together and put a pillow between their knees and tie their knees together, and then their pelvis is splinted. In addition to arteries and veins that run along the femur, you also have major nerve that run along that area as well. So when there is a fracture, there may be some possible neurovascular bundle damage. When we think of hip fractures, that's not the actual pelvis itself, but the greater trochanter of the femur, and that certainly can snap off and depending on where that ends, or pop out of joint, and depending upon where that ends up, determines whether it's a dislocation or a fracture. You can dislocate that anteriorly. The leg itself then is going to be shortened and externally rotated with those sort of fractures. The extremities, you're going to compare, the nice thing about extremity assessment is that you have a pair. In most situations, you got a right leg and a left leg, and they should be, not identical, but certainly pretty close to the same look, the same width, length, that sort of stuff. They should function about the same. And if they don't, one of the first things you want to ask yourself is that normal for this patient? Particularly if they've had a stroke in the past. Palpate the leg all the way down to the ankle. And when I do a palpation, I offset my hands and I push against each other. I think that's a better way to determine things like crepitus and to feel instability rather than just squeezing the tissue as you go down. Again, the whole reason of assessing the extremities is to look for crepitus, instability of joints, instability of long bones. Also, determining the presence of pedal edema, sacral edema, that sort of stuff, and then determining the circulation sensory motor in the upper and lower extremities. Initially we're going to look for circulation sensory motor. Circulation would be a cap refill or the presence or absence of pulses. Sensory would be wiggle, and motor would be, or sensory, can you feel me touch? And motor would be wiggle your fingers or wiggle your toes. When you do things like grip, when you do things like push-pull, you're assessing not circulation sensory motor, you're assessing strength in the extremities when you do things like grip, push, pull. So here they're checking for pedal pulses, a dorsalis, or that's not a pedal pulse. They're checking for the pulse behind the ankle. And here they're having them push, pull, and pushing and pulling is strength. It's not part of circulation sensory motor. Palpating the shoulders, palpating the chest, palpating the clavicles, holding your palms side down, hands on both sides of the chest, and having them take a deep breath to see both sides of your hands rising equally gives you a good idea if you have equal and bilateral chest rise. Here they're checking circulation, or they're palpating down the extremity, and here they're checking for grip strength, not necessarily sensory circulation motor. In assessing the nervous system, you're looking to see if they have an altered mental status. Of all the organs, your brain is usually the first organ to show dysfunction, and as a result, your level of consciousness becomes altered. And we use the altered mental status as a dividing line for things like respiratory distress and respiratory failure. The difference between respiratory distress and respiratory failure is the level of consciousness. When you no longer can maintain adequate oxygenation and your respiratory system fails, then your level of consciousness becomes altered. You could even argue that with circulation as well. When you no longer can maintain adequate circulation to your brain, then your level of consciousness is going to be altered. So, checking your mental status is an important nervous assessment, particularly if there's a history of loss of consciousness at all. Alterations in strength or sensation could be stroke. Loss of extremity function on one side, again, could be evidence of stroke. Some special considerations in infants and children when doing a secondary survey is, one, gaining their trust so that they allow you to touch and squeeze them from head to toe. Obtaining vital signs can be a big challenge, not so much getting a pulse, not so much breathing, unless they're screaming or crying, but getting a blood pressure is really difficult on children. Some will hold still, but the vast majority will not. And then you got to really question what it is that you're hearing, and if you're using a machine, what the machine's getting if there's a lot of fussing. I find the best way to measure circulation in children is to assess the difference between central and peripheral pulses, assess the difference between the carotid and the radial, assess the difference between the femoral and the pedal. If they're all feeling the same, then your pressure is good and adequate. If you have absent peripheral pulses and your central pulses are weak, you're hypotensive. Some physical exam techniques, certainly on older adults, can be a challenge. You may have to put their hearing aids in. If you do remove them, you may have to put them in, or they may ask you to put them in, particularly if they're having a hard time hearing you. So, hearing might be a challenge when you do your physical exam. If they've had previous strokes or they're on certain medications, that may enhance your ability to do a physical exam, those sort of things. Reassessment, what I like to think about reassessment is this. When I do a reassessment, I am reassessing my patient as if it's the first time I've ever seen them. And you just can't go wrong with that sort of philosophy. Reassessment requires you to repeat your vital signs, repeat your primary survey, repeat your secondary survey, that sort of stuff. And then as part of reassessment is to also evaluate the effectiveness of your interventions and your treatment. The whole purpose of reassessing a person, particularly if we've provided lots of different medications, is to see if they're getting better. As far as documentation goes, we have a whole chapter coming up on documentation, so we won't spend a lot of time, but your PCR, your patient care report, it needs to be thorough, it needs to be accurate, it needs to be consistent. It should be a very detailed record of your assessment findings. It should include things like associated signs and symptoms. Those would be signs and symptoms that we'd expect to see with a given illness or injury, as well as pertinent negatives. Pertinent negatives are, the failure of a medication to do what it's supposed to do. If I have a patient who takes nitroglycerin for their chest discomfort, and they took their nitroglycerin and it didn't relieve their chest discomfort, the fact that it didn't relieve their chest discomfort would be a pertinent negative and something that I'd want to record. So in summary, we quickly went through, quite a bit of stuff here, but we know that a thorough, complete patient assessment goes hand in hand with a thorough, complete history, and that it needs to be systematic and well organized, and it may vary somewhat depending upon the patient, how critical they are, whether they're high priority patients or low priority patients, and if they're high priority patients, we need to fix those problems before we move on to any sort of further assessment. We need to organize our physical exam in a logical pattern that completely assesses each anatomic region, moving from one part of the body to the other. And when we're dealing with children, when we're dealing with multiple patients, remember that their organ systems are immature. And that's going to lead to a variety of assessment difficulties. We'll talk more as we get into each individual system. When we talk about airway, we'll go over the differences in the anatomy and physiology of the pediatric airway compared to the adult airway. But there will be some challenges when assessing children, or when assessing multiple patients with similar illnesses or injuries. You'll have to do some triage, and we have a whole section at some point devoted to doing some jump start triage. You've got to gain your patient's trust before trying to do a physical exam, and you might be able to gain that trust as you're doing your history, when you're obtaining your history, as you're determining their level of consciousness, as you're determining their signs and symptoms, their allergies or meds, pertinent past medical history, last oral intake, that sort of stuff. You might gain their rapport, and they may allow you to do more of a physical assessment. Remember too is that as people age, so do the organ systems. And as they age, they don't compensate as well. And you couple that with medications that older patients are taking. You couple that with, just a general decline in overall health of their vital organs. And as a result, a seemingly minor problem can become life-threatening unless you don't intervene early. Excuse me. Never assume that the patient is completely stable until you've, done a full assessment. Get a good set of vital signs to establish a baseline and then repeat those. Every 5 minutes in a critical patient, every 15 in a stable patient, to help us identify trends. Completely and thoroughly document all parts of the assessment. Note what normal findings you have as well as pertinent negatives. And by documenting this stuff consistently, it'll decrease your chances of forgetting to write down critical information. One of the biggest mistakes that certainly a paramedic can make is, towards the end of the shift, I'm just about ready to get off. You have a call. In some places, they'll let you, just gather all the information and write the patient care report the next time you're on duty. And if it's 2 or 3 days and then you sit down and try to write it, that can be a challenge. All right, so that brings us to the end of Chapter 17, Patient Assessment. Should you have any questions, again, feel free to get a hold of me either through my email or my cell phone number. And with that, I will talk to you soon. There we go.